Cause of opportunistic infections again is a very rare scenario. It's not a very common scenario. Most of them are associated with pulmonary nodules, consolidation, or cavitation.
Yes, or mediastinitis.
Yeah. Just presenting as a isolated mediastinal lymphadenopathy is very rare.
It was a separate mass. Yes.
It's a rare presentation, and if these scenarios happen, generally they have a disseminated involvement in the form of meningitis or other hepatosplenic involvement.
Yes.
So that was a very oddity in the first case. Any comments about the immunosuppressive state in that patient?
That patient was not immunosuppressed. We did not have any evidence of comorbidity. If there were, I would have certainly shared that, because that would make my life so much easier, because then I would know what to suspect. But that's not how it was, and that's precisely the reason that I'm sharing this case today.
How common is hypercalcemia with fungal infections normally?
With fungal infections, sir, I have seen in 2 cases, and I have seen recently. It's not about fungal as such, I would say. It's the granulomatous infections, because wherever you find granulome, that's where you find. I recently had a patient with tuberculosis. He had disseminated tuberculosis.
So you would see more in either tuberculosis or sarcoidosis rather than fungal infection.
Sir, again, granulome. Wherever you have a granulomatous disease, it's a sink. It's a sink for dystrophic calcium metabolism, and that's where there's a role, and you'll find.
That's because of extra renal 1-alpha hydroxylase stimulation causing increased calcitrol formation. That's a mechanism in granulomas. And in fact, you would rule out a malignancy based on calcium level in such a patient, because in malignancy the calcium level would be much higher, probably more than 14. But here the calcium level was 11.3 or something. So one would actually think more of sarcoidosis or tuberculosis as a granuloma. I am not sure how much fungus causes a granulomatous stimulation of 1-alpha hydroxylase.
So histoplasma is classically known to be associated with hypercalcemia, but what I personally feel, in this case the vitamin D was more than 150, and this patient was actually on vitamin D supplementation. The first thing that came to my mind was this is vitamin D toxicity.
Dr. Parminder, your comments about hypercalcemia in this patient?
As he was saying that if it is granuloma, then probably 1-alpha hydroxylase activity becomes quite high, and that creates calcitriol and causing the hypercalcemia. 2 fungal infections, histoplasmosis and crypto, both were there, and both are known to cause hypercalcemia, right? Although, as the comment was that sarcoid and tuberculosis are much more common, and hence more commonly associated with hypercalcemia as compared to these 2 fungal infections.
Very nice presentation, Dr. Keerat. Another question. You said about pericarditis, and in tubercular meningitis we use steroids. And how about in tubercular pleural effusions? Because in our PG days we used to give a lot of steroids in large pleural effusions in tuberculosis.
So it's not advocated unless there is IRIS. That is somebody who's on ART and who's been started on ATT, has developed an inflammatory syndrome. Only then, otherwise it's not advocated anymore. It's not a part of the current practice. It's advocated against nowadays.
Absolutely not used these days?
Not at all. But I appreciate this question, because this is a very common thing that I have come across, and it's absolutely not a part of our protocol. Dr. Kashdeep, your take on this, please.
Normally in isolated tubercular pleural effusion, it is unilateral, there is no role of steroids. But if it is bilateral, massive, associated with evidence of pericarditis, then definitely yes.
Then it comes to pericardial disease again.
But if it's a large effusion, bilateral one, you want to buy time, then you have to give. If there is features of adrenal insufficiency along with that, you have to give.
Absolutely. Yes. Thank you so much.
Last year, ATT was not started.
It was started, and then the patient took it from a local dot center, because they saw my notes, so they were like, oh, is this rifampicin resistance? Because the Nikshay portal is such a wonderful initiative by the government. They had documented that the reason for testing The reason for testing is BR-TB status. So because my bronchoalveolar lavage had documented rifampicin resistance, they tested again. It was negative. Sent to the local Fatehgarh Sahib. They took the result.
Did she receive ATD for this?
For 6 months, yes.
Over there.
From the local dot center. They shifted her to local dot center because when they tested, there was no rifampicin resistance. So they were like, look, they started drug sensitive TB treatment.
What do you think why she got the second?
She got bad lungs. Why she got that? Because of the critical narrowing at the left main bronchus. This was progressive loss of parenchymal integrity. And beyond that, see, also you have to understand the sampling which they did. They took a sputum sample for testing. We went in and we found that there was persistent MTB positive culture. So there's no denying a culture. Once you have a culture, like I said, that should we treat somebody who has persistent gene expert or TrueNAT positivity after having had tuberculosis? So the answer is that that's not enough of a premise to start ATD. Someone can have a positive gene expert or RT-PCR for up to 7 years post ATD. So one has to be very, very cautious with that about what evidence you're taking into consideration when you're thinking of restarting ATD. And my evidence was actually the culture sensitivity. The fact I started it earlier was just based on what evidence I had at that time.